All right, welcome to module number 2. This is our introductory material for the cervical and the lumbar spine. My name is Dr. Luke Haynes, PT, DPT, CHDN, Cert DN. You should have gone through your course from a couple of weeks ago on the introductory material. Today, we'll actually get into some needling situations. Let me go ahead and make this a little bit larger. There we go. So again, a little bit about our material here. So the Haynes method of neuromuscular dry needling is a hybrid. The hybrid dry needling certification course is a 64-hour dry needling certification presented in a hybrid context, with 32 hours being a live synchronous virtual lecture in the module, and the other 32 hours is going to be live in-person lab sessions. Module is broken, excuse me, into 16 two-hour modules, which occur every 2 to 3 weeks on Mondays, and now it's on Tuesdays from 6:30 to 8 p.m. There's an introductory 8-hour in-person dry needling lab after the first 4 modules, and the advanced in-person dry needling lab is an intensive 3-day, 24-hour lab session that will occur after the 16th module is completed. Those participants who've successfully completed the entire course and wish to demonstrate advanced clinical competency can sit for both a written and a practical examination, which, upon successful completion, will lead to a certification in the Haynes method of neuromuscular dry needling, or the CHDN. Let's see here. What we're going to cover today in our virtual module for the cervical and the lumbar. We covered the required supervision last week. We will now start getting into some surface anatomy and some 3-dimensional anatomy. We'll talk a little bit more about needle placement, location description, and we'll look at some supporting evidence. We'll talk about some clinical decision-making, and then we'll look at our dry needling technique demonstration in the axial spine. For the cervical spine, we'll look at the listed muscles, and we'll go into each of those in detail momentarily. So some supporting evidence, study by Gildeer. It was a randomized trial of trigger point dry needling versus sham needling for chronic tension type headache. The results here, the dry needling group, the intensity, frequency, and duration of headache, and the short scores, the scores of the short form 36 subscales were significantly improved after treatment. In the dry needling group, all the effect sizes for headache variables were large. So the conclusion there, the results of this clinical trial suggest that trigger point dry needling, or dry needling, in patients with chronic tension type headache, is effective and safe in reducing headache intensity, frequency, and duration, and increasing health-related quality of life. We go and look at another from Tazun. This is on the effectiveness of dry needling versus a classical physiotherapy program in patients with chronic low back pain. And it was a single-blind randomized controlled trial. And this was done in 2017. Here, the purpose, they compared the effectiveness of dry needling with a classical physiotherapy program in patients with chronic low back pain caused by lumbar disc hernia. The results in the study group, the calculated Cohen's effect sizes were bigger than those in the control group in terms of pain, trigger point related variables, and fear of movement. The effect sizes for reducing depressive symptoms were similar in both groups. So the conclusion, the results suggest that dry needling can be an effective treatment for reducing pain, the number of trigger points, sensitivity, and kinesiophobia in patients with chronic low back pain caused by lumbar disc hernia. So some clinical decision-making. We want to look at what I'll refer to as some movement system abnormalities. Our regions can be the cervical, thoracic, the scapula, the cervical thoracic junction, the scapulothoracic junction, the costovertebral junction for the cervical spine. And the lower body will have both the thoracic, the lumbar, the sacropelvic, sacropelvic, the thoracolumbar junction, lumbosacral junction, and the sacroiliac junction. So have to look at all of those components together when dealing with a pain or a restricted movement in that area. So what do we want to assess? We're going to want to look at strength. We want to address it both through our individual muscles, but also in reference to myotomes. We want to evaluate our range of motion. We want to look at movement patterns. Is something, is the movement symmetrical, left versus right? And then with our pain pattern, is it focal pain or is it radiating pain? Tenderness is a big point of concern when dealing with dry needling. General rule of thumb, that nodule of tenderness, that focal point of tenderness, is going to be our focus of what we want to do as far as needling. In there, we're going to have a movement pattern, and odds are there's going to be a dysfunction in there, either a flexibility or strength issue, maybe an asymmetry one side versus the other. So that tenderness kind of is a center point, and we move out from there based on what's involved with that movement pattern. Also, is there any altered sensation? And is it a dermatome type alteration, or is it peripheral innervation? Is it central or is it peripheral? So that's definitely part of the assessment in our clinical decision making. We also want to know where to needle. In the cervical spine, we'll start by doing some vertebral springing. So is that a discogenic origin? We also will look at palpation of our cervical tenderness. We'll look at everything from the external occipital protuberance all the way down to T4. There we'll look at our paravertebrals from the spinous process laterally to the articular pillar, and we're just looking for tenderness in those associated locations. We'll look from the center suboccipital laterally to the mastoid process and to the transverse process of C1. So we'll look at cranial to caudal and then midline to lateral. Sorry, Bart, you looked at that. The articular pillar, a very important aspect of our pain in the cervical spine. We definitely want to look at that. Now we'll identify it in this introductory material. It's not until we get into the advanced module that we actually start looking at dry needling here laterally onto the articular pillar. Definitely want to evaluate the upper trapezius. Any upper body from the cervical spine down to mid-thoracic, we're probably going to have some sort of upper trapezius pain, tenderness involved with that. We also want to look at the superior angle of the scapula. Any scapulothoracic or cervical thoracic issue probably has some issue in that area as well, deep to the upper traps, so that superior angle important. In here, we want to identify our tender bands or nodules, or if you want to call it trigger points, but we want to identify where those are, and we want to compare that left versus right. And then, is there aggravation through active, passive, or resisted movement? Those are definitely things of concern that we want to look at. In the lumbar spine, again, we want to look at our vertebral springing. Is it a discogenic issue when we do that? Moving from there, we look at our palpation of our lumbar tenderness. From T12 all the way down to S2, we want to look at our paravertebrals from the spinous process laterally past the iliocostalis. We want to look at the iliac crest itself. We want to look at PSIS. PSIS is frequently in any low trunk lumbosacral problem. Odds are we're going to feel some significant tenderness there on that PSIS. And lastly, there our sacroiliac sulcus as well. And then we'll look at some in the introductory material, more in the advanced module on the importance of that SI sulcus. Again, what we want to identify are tender bands or nodules. We want to compare left versus right as far as that tenderness. And then again, we want to assess our aggravation through active, passive, or resistive movement. So I've just put this map up a little bit, the dermatome map. When we're looking at specific areas that we want to dry needle and evaluating, making that clinical decision-making process, we want to be aware of where we are in our vertebral level and how it's reflected in the dermatome map. So if you don't have one, you definitely want to keep one on board. I've also got, if this will play, let me come down a little bit. Okay, so inside the 3D anatomy model that I use, it does have a dermatome map. And I just use this as an example. Sometimes it can be helpful to look at it in a three-dimensional approach. I could take this model and I can rotate it back and forth. I can invert it. I can, again, look at it however I want to. Any tool that makes it easier to remember and visualize where these dermatomes are in reference to where your tenderness is, if there's a strength issue, if there's a sensory issue, that can be helpful. And again, so we look at our dermatomal patterns. We also want to be aware of our peripheral innervation. And the reason for that is some things could be more of a spinal issue. So if there's a herniation or any sort of impingement at the spinal level, definitely we'll see more of that dermatome pattern. If there is a problem of a nerve entrapment and one of the entrapment zones, then we could probably start thinking more along the lines of specific nerves. And when we get to our perineural, excuse me, dry needling, that part becomes much more important, because that's where we'll find these specific areas that we want to identify that we can evaluate and needle specific for that. So two different nerve situations that could be relevant. So for our 3D anatomy, we want to look in our axial spine in the cervical. We'll look at the Splenius Capitis, Cervicis, and the Erector Spinae group, the Spinalis Cervicis, then Semispinalis Capitis, Semispinalis Cervicis, and Multifidus. In the lumbosacral spine, we'll look at our Interspinalis, Longissimus, Iliocostalis, the Multifidus, and although it's not a muscle, we definitely want to look at the PSIS. In the axial spine, we'll start with the Splenius Capitis. And I tell you what, I think what I'm going to do is walk all the way through this, but I want to do this in a 3D approach as well. But we'll run through this briefly. In the Splenius Capitis, the origin is the lower half of the ligamentum nuchae and the spinous process of C2 to C4. It inserts into the mastoid process the skull below the lateral third of the superior nuchal line. It's innervated by the posterior rami of the middle cervical nerves, and its action together, it draws the head backward, extending the neck, and individually it rotates to the same side. That's Splenius Capitis. This is information that comes straight out of Henry Gray from 1918. Great information. I'm not going to read all of this to you, but it's in the in the PDF of the lecture that will be available on the student portal. Splenius Cervicis. Here, the origin is the spinous processes of T3 through T6, and it inserts into the transverse process of C1, 2, and 3. Again, innervation, the posterior rami of the lower cervical spinal nerves, and its actions. Bilaterally, it extends the head and neck, and unilaterally, it laterally flexes to the same side and rotation to the same side. In the Erector Spinae group, the Spinalis Cervicis. Here, origin, the lower part of the ligamentum nuchae of the spinous process of C7, sometimes T1 or T2. It inserts into the spinous process of C2. Posterior rami of the spinal nerve, innervation, its action being the smallest of the subdivision, it interconnects the spinous process of the adjacent vertebra, most constant in the thoracic region, and it can even be absent in the cervical region, where it is associated with a deeper Semispinalis Capitis. We're going to assume that it's going to be there, and we've targeted developed a strategy for specifically targeting spinalis surfaces, whether it's there or whether it's absent. Then into the Semispinalis Capitis. I target a lot of my first level of dry needling for headaches based on Semispinalis Capitis. Very common to have significant tenderness in this muscle, and you can follow it as you do your palpation adjacent to the spinous process all the way up to its attachment. And I've found that that is a significant, a very nice target when dealing with your first level of headache. If they're significantly compromised, then we get to our other levels. and we can go deeper and bring other muscles along. Anyway, Semispinalis Capitis, the origin. It's the transverse processes of C7 and T1 through T6, and the articular processes of C4 through 6. It inserts into the medial area between the superior and inferior nuchal lines of the occipital bone. It's innervated by the posterior rami of the spinal nerves. Its actions, again, bilaterally, it pulls the head posteriorly, individually pulls the head posteriorly and turns it. The Semispinalis Cervicis. A little deeper. Its origin, the transverse processes of the upper 5 or 6 thoracic vertebrae, inserts into the spinous process of C2 through C5. Again, innervation is posterior rami, and its action, bilaterally extending the vertebral column, individually turns or rotates in the opposite direction. And the multifidus. So this describes all of the multifidus. The origin, the articular processes of the lower 4 cervical vertebrae, and inserts into the base of the spinous process of all vertebrae to C2. Truly, the multifidus extends all the way down into our sacral sulcus, and it follows the same path of origin insertion going all the way up. It is innervated by the medial branch of the dorsal rami. Its action, it is stabilizes the vertebra and local movements of the vertebral column. Globally, it can contract bilaterally to extend the vertebral column and contract unilaterally to produce rotation in the opposite direction. Very commonly dealing with our cervical and our well, thoracic as well, but lumbar. The multifidus is our prime stabilizer, and that is our target with our dry needling. So that is one of the reasons why we use our vertebral lamina as our backdrop for a dry needling for multifidus. So I'm going to stop that and let's go look at that in our complete anatomy. Let me escape out of that. All right. Where are we here? Okay, so let me expand this just a little bit. Okay, that's all it's going to let me do. So looking in the cervical spine, I'm going to start from superficial and go deep. Actually, let me come back. Let me share this. I apologize, moving back and forth between a PC and a there we are, PC and a MacBook. I get a little confused sometimes. All right. Okay, so let's start superficial and then we'll go deep. Probably most superficial that we're going to see is our Splenius Capitis. As you can see, it has an origin that extends into the thoracic spine around T2, or C7 to T3 actually is what it says, and inserts into the mastoid process. So I've got that. I'm gonna hide that so that we can see beneath it. And again, we discussed this as being one of our more involved with headache. We get a lot of neuromuscular tension, especially in the medial fibers of the muscle as it comes up to its attachment. So an important there, Semispinalis Capitis. We'll hide that. We'll get into, here we see, and get it a little bit larger, our Spinalis coli or Capitis, Spinalis Capitis. Again, sometimes it can be absent, but with our targeted approach to needle these muscles, we're gonna hit that. Beneath that is going to be Semispinalis Capitis, and beneath that or anterior to that is going to be our multifidus. So, well, let's come here one more. The Splenius Capitis, again, long, extends all the way up. So with that in the cervical spine, you have to think, wow, that's an awful lot to try to get to. But I'll, when we get to it in just a little bit, there's a targeted approach with 2 needle locations that we can get all of these muscles with those 2 needles. But we'll discuss that in a little bit more depth in a moment. So let me stop that share. Now let's come back to here. All right. So in the posterior cervical spine, first thing we want to do is we're going to assume that we've gone through a physical exam. We've checked our range of motion, we've checked our strength, and we've done some. Now it's time to do some palpation. You know, where are things tender? Where are these nodules? Where's the actual complaint? What is hurting? I've got it printed out here in picture and in slide, but what I want to do is come on down and show you this in video format. Again, this information is all presented in the PDF that's available on the student portal. So let's come to now. Here. I don't think that's the one that I wanted. I'm going to stop that share. Let's try this again. All right, I'm going to have to minimize some of these. Wasn't what I wanted, but again, PC versus Apple. I guess I just need to pick one and stay with it. Okay, here we are. And bear with me, my moderator is giving me a message. I'm still waiting on my moderator. Okay. Okay, so surface anatomy of the cervical spine. So we'll start by taking a look at our surface anatomy of the cervical spine. We'll start with some anterior structures first to give us a point of reference for identifying posterior structures. And so let me bring up my pen. The structures anteriorly that we'll look at first will be the hyoid bone. Second, we're going to look at the V-notch of the thyroid cartilage. Thirdly, we'll look at the smooth lateral surface of that thyroid cartilage. We'll then look at the cricoid cartilage, and then lastly, the sternal notch further distally. So these would be our anterior structures. Okay, so let me clear that and let's look at it from a lateral aspect. So how these are going to correlate to our structures posteriorly. The reference is going to be a little bit from a inferior to a superior posterior angulation, simply because of the cervical lordosis that we have. But if you place your hand underneath the mandible, underneath the jaw, and let me drop that down just a little so we can see everything here. Okay, so there we are. So we look at hands underneath the mandible. You can have your subject swallow. You'll feel that hyoid bone move. That's going to have a direct correlation with the spinous process of C3. My line is not exactly straight, so let's try that again. Here we go. There we go. So there we have C3. The V-notch of the thyroid cartilage, and these are all palpable, you can palpate them on yourself, is going to orient to C4. The smooth surface of the thyroid cartilage itself is then going to align with C5, and then further distally, and it sits right about here, as a smaller, harder structure, the cricoid cartilage, and that is going to orient to spinous process of C6. We drop down a little further distally. Again, the sternal notch sitting right here at the junction at the upper end of the sternum, the manubrium, where that's orientation will be relative to the spinous process of T2. Okay, so let's look at our surface anatomy from a lateral aspect. Some structures we'll be interested in here. Number one will be the mastoid process, just inferior to the ear. We can palpate that. Excuse me. Just inferior to that will be the transverse process of C1. Another structure of importance, especially as we get later into our course, will be the lateral arch, our laminar arch. And so that's on most people that's fairly easily palpable. It can be tender, especially if someone is having some posterior lateral symptoms, but that is going to be an important landmark for us to discover a little bit later. So let's move from here. Let me clear that, and we will move posteriorly now, and let's evaluate some of our important landmarks here. So let's start first with the external occipital protuberance, easily palpable in this area. There are then going to be three lines of importance, really two, but there's three here, so we'll discuss all of them. First is the supreme nuchal line. Adjacent to the external occipital protuberance will be the superior occipital protuberance, and then further distally and much deeper will be the inferior nuchal line. So supreme, superior, inferior nuchal lines. Let's talk about the spinous processes posterior. C1, rather difficult to palpate if it can be palpated at all. Most commonly, C2 is our first spinous process that we can palpate. We can follow by palpating in between each spinous process and the interspinous space to find each of the subsequent spinous process. Of importance, we get down to C5, C6, C7, T1. Then we want to know, okay, well, how do I know if I'm on here? So the easiest way between C6 and C7, a person that's 40 years of age approximately or younger, when you extend the neck, C6 is going to move anteriorly, and then as you extend, it's going to come back to a normal position. C6 does tend to sit a little bit more anterior than C7 to begin with, but in a nice seated position with that extension, C6 will move forward. C7 tends to be the last of the vertebra that will have some rotation in it, and so if you place your fingers in between the interspinous space between C7 and T1 here, and then do some rotation, you should be able to feel the differentiation between the spinous process of 7 and 1 as well. As you've identified T1, you can move out laterally and palpate the transverse process of T1. If you move a little bit further laterally, then you feel the drop-off. That drop-off indicates the transition from the vertebra itself into the first rib. So that's the vertebral and rib junction interface. So that's rib 1. Likewise, if you proceed down into the thoracic spine, you'll notice that as well. If we've identified T1, we can look at the sternal notch anteriorly, and we know that is T2 as a reference spot. Okay, let's drop into the thoracic spine for our last little piece here. We came in, we identified transverse process of C1 and the spinous process of 2, 3, 4, 5, 1, 2, 3, 4, 5, 6, and then here we are at C7, and then we get to T1, which is our first rib articulation. So for one of our needle placements today, we want to look at something a little bit further into the thoracic spine. So if we look at the spine of the scapula, we can draw a line from the root of the spine of the scapula across, and the general location, see T1, T2, will be between the spinous process of T3 and T4. Generally speaking, we'll call it T4. So that is location. Now the spinous process sits much further inferiorly than the vertebral body itself, but for our point, the root of the spine of the scapula will represent T4. Okay. We'll stop that share. I'm going to come back to our lecture piece. Let me come up. Perfect. All right. So that's surface anatomy for the cervical spine. Do I go through each and every one of those things every time I needle someone? For the posterior piece, probably not as much as we get into the two specific ones. Needle points to include all of the posterior cervical structures, then yes, I will need to at least be able to identify C6 and T4. In the advanced module, when we get into the lateral cervical spine, we'll definitely want to make sure, be very precise with our palpation because of location of a lot of important structures there, neuromuscular, neurovascular structures. We move further into the lumbosacral spine. Here we look at interspinalis, longissimus, iliocostalis, and the lumbar multifidus. Interspinalis, I do have occasion that I will needle the interspinalis. It's not very often. It's usually one that I will needle only if there's specific midline pain or complaint. And in that case, I will needle that. But it's not that common for it to be a part of the treatment or the symptomology. But we do want to be able to address it. I have had several patients that was their issue. Here, the origin and insertion is the superior and inferior spinous process, innervated by each posterior rami segmentally, and its action is some small extension of the spinal column. Excuse me, the Longissimus Lumborum, its origin is the accessory processes and adjacent medial and of the dorsal surface of the transverse process of the lumbar vertebra and the ilium. Its insertion, the tendons converge to form the lumbar intermuscular aponeurosis. It's innervated by segmental posterior rami, and its action, it primary extensor of the vertebral column and the head, acting bilaterally. They straighten the back, returning it upright from a flexed position. So it does extend all the way, you can see, down from the inferior aspect of that sacral sulcus, almost to the most inferior distal piece of that, and it can extend all the way to its cranial attachment. The Iliocostalis, you can see, so in this picture, the Longissimus Lumborum is faded out so that you can't see it as prominently, but Iliocostalis sits further lateral from that. And so we can't needle both of those at the same time very effectively, so we have a different targeted approach for that. And they have a very distinct border whenever you go through palpation for that. The Iliocostalis Lumborum, the origin is the sacrum, the spinous processes of the lumbar and the lower two thoracic vertebra and their supraspinous ligaments and the iliac crest. It inserts into the angles of the lower 6 or 7 ribs, innervated segmental dorsal rami, and its action, primary extensors of the vertebral column and the head, acting bilaterally. They straighten the back, returning it upright from a flexed position. And multifidus, here the origin, the sacrum, origin of the Erector Spinae, the superior iliac spine, the mammillary processes of the lumbar vertebra, transverse processes of the thoracic vertebra, articular processes of the lower 4 cervical vertebra. It inserts into the base of the spinous processes of all vertebra from L5 to C2. It's innervated by the medial branch of the posterior rami, the spinal nerves, and in action, it stabilizes vertebra and local movements of the vertebral column. For global movements, contract bilaterally to extend the vertebral column and contract unilaterally to produce rotation in the opposite direction. And then lastly, we'll talk about the PSIS. Again, we discussed a little bit. A lot of patients will have complaints of tenderness upon palpation in this area. Obviously, it's just a myofascial or fascial covering at that point. As you can see in the picture there, we've got the gluteus maximus coming over. It has an attachment right adjacent to it. Iliocostalis and Longissimus likewise are there deep to that. And subsequent part of that is the ligamentous complex that has an attachment onto the PSIS as well. So although the PSIS may not be our functional cause of problem, it is frequently a focal point of pain, and I will often needle the PSIS in addition to other movement or muscular pieces as well, simply because we just find that it gets so much benefit from just needling onto that bony PSIS. So let's move from here. Let's go back to our 3D anatomy and look at that. Share. That is not it. That is not it. That is it. Okay, so that is cervical. Let me switch here. Okay, so checking with my moderator. Very good. So when we look a little bit deeper into, and I'm going to expand that there. Okay, so as we look here, there's some stuff here that we're not going to really be dealing with. Sorry, I'm dealing with my program here. All right. There we go. So there's some things I'm going to get rid of. Serratus posterior, inferior, we're not going to talk about that right now. We'll get to that, but it's not part of what we want to talk about right now. In here, we also have our QL, our psoas. That's not anything we're talking about today, but we will get definitely to that when we get to our advanced module. So in the lumbar spine, we'll go lateral, superficial to deep, and more medial. So here we see our iliocostalis, and as you can tell, it actually isn't just part of the lumbar spine. It extends all the way into the thoracic and even a little bit higher. So it is easy to palpate, and we'll demonstrate that. One nice thing is its lateral border gives us a nice location for its underlying quadratus lumborum. So that's a key that we'll use a little bit later. I hide that. And then we get more to our longissimus. And so again, it extends very far distally, and we get a lot of pain complaints in this area. And usually it has more to do with muscular tension in the longissimus. And as we'll see in a second, well, let me go ahead and hide that one. We've got one on the other side. Longissimus just sits posterior, superficial to the multifidus. Multifidus has more of a lateral to medial, more of almost a horizontal orientation, where the longissimus definitely is more of vertically aligned muscle itself. As you see the longissimus, again, it comes all the way, it goes way up there. So that's longissimus there. Multifidus, again, similar footprint as far as its distal attachment, and all the way up to C2. So we're going to needle a lot of multifidus in our dealing with the spine. I'm going to hide that so that we can get a little bit of a look here at interspinalis. Again, all it does is, I want to hide that supraspinous ligament so that we see there are actually two. There's one on either side. So whenever we needle that, and we'll discuss this, this is only time in the spine itself where we'll needle in a superior direction, just to make sure that we can get into this interspinous space. It looks like there is a lot of room in there, but it is, especially with a little degeneration, it's pretty tight. There's not a lot of room for area there. But we'll demonstrate how to effectively needle that. And then again, lastly, PSIS. I don't have all of the ligaments displayed, but you can see a lot of the ligaments, sacroiliac ligaments, do start to ultimately converge in that area. Again, with attachment of gluteus maximus and iliocostalis and longissimus, there's a lot that takes place right there. All right, so let's come back and all right. So let's look at our surface anatomy, our palpation component of the lumbar spine. At the PSIS, again, the lab will actually demonstrate this. So instead of reading all of this, let's come down to this part. And I'm going to stop sharing there. And let's go grab that. And there it is. Surface anatomy for the lumbar spine. We will start by looking at our inferior aspect and then moving more cranially. So we look at, first thing we'll do is we're going to trace the iliac crest, and we're going to do this on both sides and follow it down till we can identify the PSIS. If we draw a helper's line between, let's draw that a little bit better, between the PSIS, its orientation is roughly going to be at the level of S2. If we move S2, move superiorly, we'll drop off of that spinous process, and then we can palpate S1. Moving further superiorly, it's a lot smaller, but we palpate for the space in between S1 and the next identifiable spinous process, which obviously will be L5. L5 is fairly deep and it almost feels like a pencil eraser. If you need to differentiate between L5 and S1 to make sure that you're in your right spot, then what we can do is do a springing action. Use the ulnar side or the hypothenar side of your hand onto that spinous process. L5 will move anteriorly and S1 will remain stationary. We can draw another helper line at the level of the iliac crest, and that will help us identify L4. So from there we can move further cranially, just palpating between each of the interspinous space between the spinous processes to identify L3, L2, and then finally L1. To get a good idea of where we are as far as the thoracolumbar, the TL junction, we can find the 12th rib. We can follow it medially, and at the level of the spinous processes, the spinous process above will be T11, and the one below will be T12. Some more information, and I'm going to clear that information. Some more information. So the facet joints, the zygapophyseal joints themselves are going to sit basically in line with the spinous process. Inferior aspect will be at the spinous process. The superior facet will be at the spinous process of the vertebra above. So they're going to sit about 2.5, 3 centimeters lateral from the middle of the spinous process on average. The transverse processes, L1, L5, not going to be palpable. L3, probably the largest of the transverse processes. Odds are that can be palpable. More often than not, again, similar, going to find that they're going to sit midway between the spinous processes. L2, L4 possibly palpable. L5 is going to be buried behind the ilium, and then L1 is just too narrow and hidden as well. And so those are the framework for the surface anatomy we need for this course to identify our needling spot, which is going to be adjacent to L4. Okay. So let's come back here. Okay, so I also have a live version that I've recorded. And I use the recording because well, it's recorded. I can use that. It takes a little less time. So let's now share. And I'm going to have to bring it up. And bear with me. On our surface anatomy of our posterior cervical spine musculature, we can get a good idea of where we're dealing with posteriorly by our anterior structures. I don't necessarily do this with every patient, but it's a good frame of reference for us to utilize. So what we'll look at is our hyoid bone, our V-neck or our V-notch of the thyroid cartilage, the smooth side surfaces of the thyroid cartilage, then the cricoid cartilage, and then lastly the sternal notch. So if you come in with your patient, with your subject, and just gently place your finger and thumb underneath their mandible, you can then have them try to swallow. When they do that, you will feel the hyoid bone moving up and or down. You want to be careful. It is a fragile structure, so don't try to choke your subject. But that will give you an idea here. So hyoid bone. If we look in a direction, and this line of movement is going to be slightly anterior inferior to posterior superior because of the angle of lordosis in the cervical spine. So we identify the hyoid bone right here. That will give us C3. We drop down into the V-notch of the thyroid cartilage. That will correlate to C4. We drop down laterally, and on the thyroid cartilage itself, we'll be able to feel a smooth aspect on either side. That's going to correlate to C5. We drop down a little bit further, and we're going to find a smaller but more rigid, a cricoid cartilage, and that's going to correlate to C6. If we drop down a little bit further to our sternal notch, if we translate that posteriorly, that will get us to T2. Okay, so on the lateral aspect, let's talk about our landmarks. Laterally, we want to identify and palpate the mastoid process. Right there. And then as we run distally, our first lateral structure we'll come to is the lateral transverse process of C1. And it's just going to be about a finger breadth below the mastoid process. Very frequently that can be a tender location. Another important structure is the articular pillar or the laminar arch. So we'll want to identify that and its anterior-most border. And there's a reason for that. So that would comprise our laminar arch, our transverse processes on that side. As we get further into the course and talk about scalenes, other structures, this landmark will become incredibly important. So from our posterior aspect, we have several things to look at. First, we want to identify the external occipital protuberance. As the skull comes up, and forms the crest. It will be the most notable point right in the center. For our sake here, put a little dot there. You don't have to mark that if you don't want to. So superior to that, we have three nuchal lines. The supreme nuchal line, which is a little bit harder to palpate, but you will notice a ridge that runs across from medial to lateral. At the level of the external occipital protuberance, you will palpate, again, a line running across on either side, and that is the superior nuchal line. A little bit lower as the skull starts to dive down in towards the cervical spine itself, and this is deep and this is considerably more difficult to palpate, we'll locate the inferior nuchal line. When we deal with suboccipitals, that line becomes more important for that. But we also want to evaluate and identify our spinous processes. So we come around. C1 is almost always impossible to palpate. An extremely thin person, you may be able to palpate that, but more often C2 is going to be our first spinous process that we locate. And so what we'll do is just march our way down. C3, C4, and C5. So we've got a few more to do. What I want to do in evaluating C6, C7, T1, however, is have them do some cervical extension. When you extend the cervical spine, for people, say, 40 years of age and under, C6 is going to move anteriorly. Over that age, because of degenerative processes, maybe there's some osteophytes, it doesn't tend to move quite as much, but that's what we want to look for, is a migration of C6 anteriorly. So I'm going to get my best guess of the interspinous space between C6 and C7. And I'm going to palpate onto each of those spinous processes. And so I'm going to have the subject then extend their neck. So we'll lift up. And then C6 does move anteriorly. This is easier done in the seated position. It requires less contraction of the Erector Spinae, the paravertebral muscles, but it still will move forward a little bit. So I know C6 and then C7 right below. So I can also evaluate C7 versus T1. C7 has a little rotation in it. So if I butt up against the spinous process, I can rotate. That spinous process is moving. If I drop down to my next and I try to rotate here, that one does not move. So this I can identify as T1. If I move laterally off of T1, I can palpate the lateralmost border of the transverse process. I drop off of that, and then I will be dropping onto the costovertebral junction of rib 1. So here is our transverse process. Here's the first rib, and then this comprises the vertebra itself, the laminar pathway here. So I also get interested, so here's T1. We talked earlier about the sternal notch. Its posterior border would be T2. So I know we're sitting here at T1 because we did our rotation, it didn't move. That would make this T2, but I'm interested in T4 for our purposes for this, the dry needling we'll do here. I want to find the spine of the scapula. I'll use this one over here. And so my spine of my scapula, here's my medial scapular border coming here. Okay, spine of the scapula is going to travel along this direction. I'm going to carry that all the way to what I'll term the root of the spine of the scapula. And we can do it on each side. But basically, between T3 and T4 resides, if we draw a helper line, the spinous process of T4. So if I'm looking for T4, I find my spine of my scapula, and that gives me T4. Again, this is where we found T1 and 7. There's 2 and 3. Okay, in the lumbar spine, where we want to start identifying our landmarks is we'll start distally and make our way more proximally. So first thing you want to do is palpate for and identify your iliac crest. We'll come around, we'll mark those on each side. Ultimately, our goal is to identify our PSIS. So we have a really nice landmark here. I'm going to draw a helper line across. So at the midline of our helper line is S2. Try to draw that upside down. S2. If we come from S2, we'll drop off onto S1, and then between the next step up is onto L5. Now L5 is a smaller spinous process. If you want to differentiate between S1 and L5, you can come in with your thumb and another helping finger to bounce or spring that. L5 will move. S1 will not. So there's my L5. Okay. So here's 1. Here's 5. Now, I'm going to draw another helper line at the apex of the iliac crest. In the midline, that will be L4. Right there. So we've got L5, L4. We can verify our location here simply by palpating the spinous processes, moving superiorly. So here we have 4, 3, 2. That should be 1. If we want to verify, what we can do is locate our 12th rib. So we identify that, and then we mark it as it's coming up towards the center of the spine. Okay, coming up to here. So where that 12th rib intersects, the spinous process superior will be T11, and the one inferior will be T12. So here's 11, 12, 1, 2, 3, 4, 5, S1, S2. In the lumbar spine, we also consider our facet joints. So in our facet joints, they're going to basically be at the level of the spinous process. So here we have L2. At L2, and it's about 2 to 3 centimeters lateral from the spinous process. That'll be the location of our inferior facet joint for L2. The superior facet joint will be at the level of L1. And so, roughly speaking, the facet joints correspond to the spinous processes as they travel down the spine. Our transverse processes are also going to be at the level of the spinous process. Because of the shape and the length of the spinous process, L1 is going to be 1 to maybe 2 vertebrae higher than the spinous process. So let's say for L2, 1 to 2 finger breadths, more likely 2 finger breadths, I should say. So the transverse process will be more lateral, but it's going to be superior to the spinous process. L1 and L5 really are not palpable. L5 is hidden by the ilium. L1 is too involved with the 12th rib. The transverse process of L3 typically is the largest, and it will be fairly deep, but frequently palpable here. L2, L4 can be palpated. An extremely thin patient, you can get to those. Most of us bigger bodied, and I'm speaking to myself, people harder to get to those, but that's roughly our distance as far as landing on the transverse process. All right, stop that. Okay, let me come back to a share here. There. Okay. And our done that. Okay, so talk about some general considerations. Needle placement location is determined, and we've talked about this, with the first consideration for safety to avoid the danger zones, and the second consideration for the maximal therapeutic effect. Needle location is frequently determined as a certain number of finger or thumb breadths from certain anatomical structures identified in our palpation labs. When referring to a finger or thumb breadth distance, remember that the distance of measure is based on the finger or thumb breadth of the patient, not of the clinician. So I'm 6'3", and I've got some fairly large hands. So my finger, my thumb, my finger breadth are going to be significantly different from a 5'2" small person. So you use your subject or your patient, use their finger breadth as the zone, as your target for what you want to identify. When needle using the spinous processes as a reference, the distances from the lateral aspect of the superior of the spinous process at the superior-most aspect. So you find that upper lateral corner, and that's where we're going to make our 1 or 2 finger breadths. Almost always it's 1, especially in this introductory needling lab. In areas where there is a palpable bony linear surface, such as the spinous process of the spine, the tibia, the spine of the scapula, the tips of the fingers can be used to hook with a profundus grip over those bony landmarks. And when inserting a needle, first determine the desired needle placement location. You're going to use the index and middle fingers. You're going to apply firm pressure as you splay the fingers apart to tighten the skin at the point of needle insertion. Very important, rapidly tap the handle of the needle that extends beyond the insertion tube to quickly depress the needle through the outermost layers of the skin. Then you can remove and dispose of the application tube and grasp the handle of the needle in preparation of advancing the needle in the desired angulation and depth with or without a backdrop. Again, that rapid tap is very important. Now, you don't want to jam that guide tube into them because that's uncomfortable, but a really quick, rapid tap lets you break through that surface tension. We've talked about the needle manipulation in the first lab, either pistoning, bidirectional rotation, unidirectional rotation, or doing that to use some tenting. So we'll move on now to our actual start of needling. So in the cervical spine, we have identified 2 locations where we can needle these 2 locations, and with those 2 spots, we can get everything of the cervical, posterior cervical musculature. As we went through the 3D anatomy, it's obvious there's a lot of larger muscles, a lot of smaller muscles, and it would be very challenging to get all of them and know that we're hitting everything. So if we take what I'll call a shotgun approach and just try to make sure that we get contact with every muscle, we have these 2 locations at C6 and T4 that give us that opportunity to do that. Again, needle inclination at 1 finger breadth from the spinous process for the multifidus should be a 15 to 20 degree medial and caudal angulation in each plane, perpendicular to the skin surface or relative orientation of the vertebra to contact the base of the spinous process on the lamina. So we want to remember that 1 finger breadth. And we always, except for interspinalis, which we'll touch base with later, we always want to angle that needle, the tip of the needle, medially and inferiorly. As long as we do that, we don't run the risk of migrating laterally into the lung field or any neurovascular structures that we don't want to stay, that we want to stay away from. In the advanced module, we can modify this a little bit, but these 2 needle locations give us what we are looking for again, a shotgun approach for the cervical spine. In order to ensure patient safety, needling at the spine, using the lamina as a backdrop, the angulation of the needle must be inferior, medial, and caudal. Any angulation in another direction would increase the risk of the needle advancing into the spinal column, into the dural space, or laterally into the lung field. So finally, down to the following muscles: Splenius Capitis, Spinalis Cervicis, Semispinalis Capitis, Semispinalis Cervicis, and the Multifidus. Here, patient's going to be in the prone position. Depending on the patient's size, we're going to use a 30 to a 50 millimeter needle. I can tell you, and again, I'm a big guy, my cervical spine requires 60 millimeters to reach the lamina at C5, C6. Precautions here are deep cervical artery and vein, anterior ramus of C6, 7, the accessory nerve, and the central canal. Here we're going to needle the spinous process of C6. So we're going to come down. We're going to identify that superior lateral most part aspect of the spinous process of C6. And we're going to go one single finger breath lateral. It's going to be posterior to anterior with 15 to 20 degree medial and inferior angulation as we drop that needle, looking to land on the lamina. All right, so let me stop that share. And let's see. And so here we are. The Splenius Capitis, the Spinalis Cervicis, Semispinalis Capitis, Semispinalis Cervicis, and the Multifidus will all be needled in one location. Patient's going to be in the prone position. Needle length, we're going to be 30 to 50 millimeters. Backdrop will be onto the cervical lamina. So we're going to locate the spinous process of C6. It's going to move anteriorly with extension as compared to a stationary C7. Needle placement will be one finger breadth lateral from the spinous process of C6. Angulation will be about 15 to 20 degrees, both caudal and medial, down to the lamina as a backdrop. Okay. So the second will be what we call CS2. Thank you. So let me stop that. And let's look down. Let me find it. For Splenius Cervicis, the patient's going to be in the prone position. Needle length will be, again, 30 to 50 millimeters. The backdrop is going to be onto the thoracic lamina. Locate the T4 spinous process as it sits 1 to 2 finger breadths distal to the root of the spine of the scapula. Needle placement will be 1 finger breadth lateral from the spinous process of T4 in a P to A trajectory. Again, 15 to 20 degrees caudal and medial angulation down the thoracic lamina as a backdrop. Okay. Okay, so come back now. Okay, so those are two cervical needle locations both for well, all of the musculature, all of the gross musculature in the posterior cervical spine. Now, I say that if you evaluate this patient and there is tenderness at C4, well, absolutely move that needle placement up. These two needle placements can be moved anywhere in the cervical spine, but truly all the way from C2 all the way down to S4. So this same needle placement can be done anywhere along the vertebral column at 1 finger breadth lateral from the spinous process. With that medial and inferior angulation, you have safety with that, as long as you've taken a good history and you're certain that there is no potential for surgical laminectomy, in which case there is no backdrop to drop onto. So except for in that case, this needle placement is fantastic up and down the length of that spine. These two are identified simply to make sure that we do make contact with every muscle in the cervical spine. Okay, now we'll jump down to the lumbar spine, and here we'll needle longissimus and a multifidus at the same time. We'll come laterally. We'll needle iliocostalis, and then we're going to needle the smaller interspinalis in the middle. And so all of this information is going to be located inside the PDF of the lecture. So what I'm going to do is come on down. And we know we're going to play 6, 7, and 8, and 9 for PSIS. Ultimately, it's going to look like that. So in midline, I'm in between L4 and L5. You can see a needle location that is for interspinalis. Lateral to that on either side is for longissimus and multifidus. And then out to the side is our approach to land in this lateral border of iliocostalis, and that's more in a transverse plane with a much smaller degree of posterior angulation. So let's move from there on now. Let me stop that share and escape there. And let's go look at make sure I'm not missing one. There we go. All right, so let's there. In the lumbar spine, for the longissimus and the multifidus, patient is going to be here in the prone position. Needle length will be 40 to 60 millimeters with a backdrop onto the lumbar lamina. We're going to palpate for the spinous process of L4 at the level of the iliac crest. Needle inclination will be 1 finger breadth lateral from the spinous process and should be a 15 to 20 degree anterior, medial, and caudal angulation in each plane, perpendicular to the skin surface or relative orientation of the vertebra to contact the base of the spinous process on the lamina. So let's look through that again. Come back. So I start. So I'm going to come across the iliac crest. That's going to give me my line for L4. I'm going to palpate for the interspinous space, and then I'm going to palpate for the lateral border of that. I'm 1 finger breadth lateral. I'm going to go inferior and medial, landing down about 20 degrees, landing onto the lamina as my backdrop. I piston that needle just briefly to make sure that I'm hitting my backdrop, because for multifidus, because it is so deep, we want to make certain that we get there. As you saw, when I needled that, I had to give the needle a little extra oomph, and that's primarily because I didn't tap rapid enough and I had a little bit more skin surface to get through. If you tap nice and rapid, you don't run into that problem. And even myself, after 50,000 times of doing this, still have to remind myself that rapid needle application has to take place. Okay, let's bring up iliocostalis. Where did it go? There it is. Okay. For the iliocostalis in the lumbar spine, the patient again is going to be in the prone position. Needle length is about 30 millimeters and there is no backdrop. What we're going to do is grasp the lateral border of the Erector Spinae group with a profundus grip. We're going to apply some firm pressure and splay the index and middle finger. Here we're then going to needle 3 to 4 finger breadths lateral to the spinous process of L4 with a 45 to 80 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebra. So I'm going to locate my L4, and I'm going to come lateral. I'm going to use that. So let me pause that. As you can see with my fingers, I'm doing a profundus grip to reach over, and you can feel the border of iliocostalis as it's moving caudal to cranial. And that is our identifying border. I'm going to use that. I'm going to put some pressure, and then I'm going to take that needle and I'm just going to run it straight through, straight across, a little bit, a very small amount of anterior angulation, a very small amount of inferior angulation. But you definitely want to do that to get through the bulk there of iliocostalis. Again, quick needle tap, and we'll advance there. With that, just simply targeting iliocostalis. In this particular patient, she was a small stature, small frame. 30 millimeter needle is all that would be required. Okay, let's bring up our interspinalis. For the lumbar interspinalis, position is again going to be in the prone position. Needle length here is less than 20 millimeters. We definitely don't want to enter that spinal canal. There's no backdrop. We're going to use our fingers to locate the interspinous space between L3 and L4. When dealing with the spine, this will be the only time that you will have a superior needle angulation, here with a 15 to 20 degrees anterior superior angulation, perpendicular to the skin surface. Caution for depth here, definitely less than 20 millimeters to avoid the spinal canal. So we're going to identify L4, and we're using that as our target location. Experience teaches me that L4, L5, the space between the spinous processes in the lumbar spine, is very small. So it could be that you need to have your patient lay on a towel so that you can get that needle further into that canal. If you basically take them into some flexion, that'll separate those spinous processes and make that a little bit easier. During our lab session, we'll try that up at L4, L3 or 4, and L2, L3. The space is a lot easier, so we may practice there. But clinically, if your patient is having a problem with interspinalis at L4, L5, then that's obviously where we have to treat. So a flexion position can be a lot easier to get into that location. And then finally to the PSIS. For the PSIS, obviously, patient's going to be in the prone position. Needle length here, 3 to 5 centimeters, depending on patient habitus. Backdrop, obviously, is the PSIS. We're going to palpate the vertical length of the PSIS, and we're going to use the needle to needle through the connective tissue and peck on the periosteum, locating 2 to 3 different areas on the PSIS. So again, following the ilium around, find the PSIS, and usually it's just center of mass where you find that tenderness. Frequently, I will use that needle. I will poke around. This is one case I may actually piston, not to receive any sort of a twitch response, but I want to hit that PSIS in several locations to initiate that inflammatory response. On pictures, it seems like PSIS is very superficial, and it absolutely is. But depending on how much adipose tissue you're dealing with, you may have to use a 60 millimeter or a 6 centimeter needle to reach that target depth on the PSIS. So just because it's there, don't think that a little 2 centimeter needle may get there. And in this small person, I used a 3 centimeter and barely got to it. So it may take a larger needle depth or needle length. All right. So there, let me come back. There we hit our 2 needle locations in the cervical spine. That gives everything on the posterior aspect that we want to work with. Again, those 2 needle locations can move up or cranially or distally or caudally, depending on the patient's complaint. However, those 2 locations give us contact with every muscle in the posterior cervical spine. As far as our big movers in the lumbar spine, I don't have a needle in PSIS on this picture, but again, we have our interspinalis in the center, the longissimus and multifidus lateral to that, just 1 finger breadth. We come out laterally for iliocostalis. Again, we use that profundus grip and find that lateral border, and that lets us advance the needle through there. And then finally, PSIS, again, because of its location, it may require a little bit more lengthy needle to actually get down to that, but very good clinical outcomes when we add the PSIS to our lumbar spine approach. So that is the extent of this module, and what we're looking at in our next module, which is module number 3, which is coming up in 2 weeks. Again, we'll look at, and that's going to be our junctional zones, our shoulder and our upper arm. There we're going to look at, again, we'll look at surface anatomy, our 3D anatomy, some needle placement location description, look at supporting evidence, some clinical decision-making, and then we'll get into our upper traps, our lats, in our posterior scapulothoracic region, our multifidus, spinalis, longissimus, iliocostalis. We'll hit pectoralis major. Then we'll hit what I call the pelvic rotator cuff, glute max, med, min, the TFL, piriformis, and the small hip rotators. We'll get into the appendicular structures in the shoulder. We'll look at deltoid, infra, teres minor and major. In the upper arm, we'll look at coraco, biceps brachii, the brachialis, biceps brachii, and brachioradialis. So part of the homework, if you're taking this just for your own knowledge, you don't have to do this, but if you're watching this content as part of the CEU, the certification program, so definitely want to do this. So what we're going to start with is self-dry needling of the brachioradialis. I know we haven't gotten to that yet, but this is going to be easy to get to. So in this part of the homework, your assignment will be to dry needle yourself into your non-dominant brachioradialis. To locate the brachioradialis, place your forearm on the surface in front of you, neutral position, not pronated or supinated, with the thumb pointed skyward. We're going to resist radial deviation to identify the borders of the brachioradialis using a splayed finger to bracket. We're going to identify a spot 2 finger breadths distal from the cubital crease on the superior aspect, and you may want to mark this spot. You're going to insert a needle at this spot and advance it 3 centimeters or until you reach the radial backdrop. And then there is the post-module assessment. These questions will be listed in the student portal, so I'm not going to read all of these things to you. But if you will, you need to complete this homework assignment and submit it in the arena. For those that don't have Facebook, you can simply email me with the responses. And other than that, we've completed and stop that share. We've completed module 2. We've got 2 more to go before we can be prepared for lab 1. So enjoy your time going over this content again, and we will see you in 2 weeks for module 3.